All right, so we're back with another series with Zach and I where we are recapping his time as the Chief Clinical Officer on his Tuesdays, where he's spending time with members of our team. Today's topic is biceps tendinopathy. There's two different ways that this will, typically present itself with regards to either being proximal or distal. We'll talk a little bit about both, but focus on proximal biceps tendinopathy. In this first video, we want to dive in a little bit to just differential diagnosis, some considerations for that initial evaluation, as well as some recommendations for what you would communicate to people and your home program for that first day. So, Zach, somebody comes in, they have either anterior shoulder discomfort and potentially also, or discomfort at the distal bicep. What are some things that you're thinking about? What's the differential diagnosis that you are working through on that first visit?
Absolutely, and I think distal biceps tendinopathy tends to be a little bit more clear-cut in my opinion in regards to the accuracy or the consistency of the diagnostics. With that, it should follow an extremely mechanical pattern, most notably being irritated with resisted elbow flexion and or resisted pronation, supination at the elbow. There's not as much differentials at the elbow. You should look at the forearm complex and just make sure between supinator, pronator teres, some of your forearm flexor mass, that's not complicating anything. But distal biceps tendinopathy tends to be pretty clear-cut in regards to the mechanism of injury or the onset and just some of the other differentials. Proximal biceps tendinopathy is one that I felt coming out of school and really through like my first 5 years of clinical practice was one that I had an overwhelming number of referrals that didn't always tend to be biceps tendinopathy. Or the opposite, I would get somebody with a separate diagnosis that after we started going down that rabbit hole, it always turned out to end up being biceps tendinopathy. So these are the types of people that come in with kind of that non-specific anterior shoulder pain. It gets almost umbrella labeled like a patellofemoral type pain where it's like, oh, you have anterior knee pain, it's non-traumatic, it's patellofemoral pain. And you could go into a lot of different segues with that. But when we look at anterior shoulder pain, things that we want to clue ourselves in on, the easiest thing is what are the other soft tissue there? Are we ruling out anterior deltoid? Are we ruling out pec? And if it is something that's truly muscular or soft tissue in nature, it should have a very mechanical pattern. We should be able to do length testing of that muscle and provoke it. We should be able to do resistance of that muscle and provoke it. So you should be able to tease out a lot of those different muscular influences pretty easily. The ones that can be a little bit trickier is if you have rotator cuff involvement or labral involvement, because those can be a little bit less consistent with regards to the location and the quality of symptoms as to how they present. And a lot of the mechanisms for those can also agitate a biceps tendon. So if we think about that proximal biceps tendon, it's going to get stressed whenever the hand gets away from and behind the body is going to be a very common mechanism. And then also with our overhead athletes, specifically with throwing as well. And then obviously anything that would just be your traditional biceps loading from a weightlifting standpoint could irritate it as well. So I think being very mindful during the evaluation with your diagnostics of screening in or screening out potential labral or rotator cuff or biceps involvement is important. And there's going to be some overlap in regards to those tests that may end up having some either false positives or false negatives. So for me, I like to get very detailed with the subjective history as to when and how it started, what tends to be the most consistent and provocative measures. And then when I get into my clinical testing, I like to do a cluster of tests and do a handful of different positions that may stress the rotator cuff, a handful of positions that may stress or bias the labrum and the biceps, and you look for patterning. And you look for what the patterning is most suggestive of, and ideally in this case, we'll talk about it being suggestive of proximal bicep tendinopathy. So day one, depending on how irritable it is, this is somebody who's either walking around with constant daily pain. If it's that individual, I'm thinking symptom management first day. The probably more common presentation we get is with day-to-day activities, it's not that provocative, but they have a consistent task that whenever they try to do it in the weight room or whenever they try to do it at work, this is the limiting factor that keeps them from going 100% or from going all out with that activity. So from a mobility standpoint, things that I want to clue in on: what does humeral extension look like? What does horizontal abduction look like? And what does overhead motion look like? And then depending on what those come out, that's going to dictate what some of your selection for entry-level mobility work is going to be. But then in addition to that, we want to get them loading with some localized tissue tolerance day one. Typically, isometrics are going to be the easiest way to do that. I had a conversation with actually Mason about this, though, is isometrics are good because they're self-limiting. They can also be very poor because they're self-limiting as well. And I have some people that you give them an isometric and you're basically trusting them to go at whatever RPE you're prescribing, whatever duration you're prescribing. So for some individuals, I will start off with eccentrics just because it's easier for me to know if they are doing it at the way that I prescribed it for them, because you're giving them a specific weight, you're giving them a specific rep count, and you're giving them a specific motion to go through. So for me, when it comes down to tendinopathy, I prefer isometrics, but I'm not afraid to give eccentrics earlier on, and I think it has to do with who you have in front of you, and your overall trust in them from a body awareness standpoint, and ability to not over or undershoot the activity, and just their overall accountability and means to carry out the process.
So what are some things also that you're thinking about outside of isometrics that you may also find valuable to either communicate to them or provide to them at the end of that first visit?
Yeah, so this goes hand in hand with isometrics. I told Mason, one reason I'm not a huge fan of giving isometrics for people is you have somebody that carved out time of their day to find childcare, take off of work, come in for PT, they've already gotten imaging, they've been to the ortho, they come to PT, they see you, and the only thing you give them is you tell them to stand, put their hand on their other hand, and push together really hard. It may be a great exercise, but it may not be perceived as the most valuable use of their time. So it doesn't mean you avoid giving it to them, but you want to give them some other additional things. So I'm a big fan of finding other ways to move the shoulder and strengthen the shoulder, because part of the tendinopathy could be that biceps tendon being asked to do more work than it's meant to do because other areas of the shoulder are not prepared to do that work. So I like to think in planes of motion. If the biceps tendon is primarily a sagittal plane activity, what can we do with regards to frontal or transverse plane? So this may be where you're educating them on just general rotator cuff entry-level strengthening activities. This may be where you're giving them single plane, single joint activities, your side raise variations for the shoulder. Maybe you're giving them some prone shoulder work, some things that they may not already be incorporating into their traditional weight training regimen. Or if you do want to keep them active in the gym and you're talking about your pushing and your pulling, we're finding, hey, maybe we can't tolerate overhead pressing and pulling, so we can put them at an incline or we can put them in a horizontal position. But I think outside of getting them some isometrics for localized tissue tolerance, finding ways that you can give them supplemental strength work to fill in gaps of what they're not getting outside of here, or ways that they can modify things that they enjoy doing and want to do outside of here in a less provocative means.